I don't know. The House Appropriations Subcommittee on Health and Human Services will come to order. Clerk, please take the roll.
Chair Morse.
Here.
Vice Chair Martis.
Here.
Representative Hood. Representative Braybeck.
Here.
Representative O'Neill.
Present.
Representative Puri.
Here.
Representative Farhat.
Here.
Representative Price.
Here.
Representative Skaggs. Representative Snyder. Vice Chair Green.
Present.
Representative Bolin.
Here.
Representative Meerman. Representative Kuhn.
Here.
Representative Steele.
Here.
Madam Chair, you have a quorum.
Thank you, Clerk. Rep. Price moves to approve the minutes of March 6, 2024. Hearing no objection, the minutes are approved. Welcome, everyone, to today's hearing of Health and Human Services Subcommittee. We are happy to welcome some people who will be testifying on aging services. We understand as a state that we really have to be intentional about the resources that we're putting in place for our aging population. And we thought it was important to have a hearing dedicated to aging and long-term care services so we can hear from the department and organizations that are working in this area so we can plan for those resources as we budget for 2025. So with that, we will welcome up the department first. We have Megan Groen, Scott Wansley, and Amy Epke. Please join us, and the floor is yours.
Good morning, and thank you for the opportunity to be before this committee again. My name is Amy Epke. I'm the Senior Deputy Director of Financial Operations with the department, and I'm pleased to be joined with both Megan and Scott today. And as mentioned, we're going to talk a little bit about aging and long-term services. So with 25% of Michigan's population over 60 years old, providing services to the aging is extremely important. In 2022, the department reorganized to create the Behavioral and Physical Health and Aging Services Administration, which is now under the direction of Megan, who you'll also get to see next week in the committee meeting as well. The administration was designed to bring services together, building a continuum of long-term support and providing individuals and families with necessary services. This morning, we'll provide an overview of aging services, discuss current initiatives, and wrap up by highlighting the investments proposed in the fiscal year 2025 budget. So with that, I'm going to go ahead and turn it over to Scott.
Thank you, Amy. Thank you, Committee Chair Morse and Committee, for the opportunity to present this morning on important work being done by the department and partners across the state to serve older adults, caregivers, and others needing long-term care here in Michigan. In our presentation, we're going to give you a bit about the older adult population of the state. As you can see on the slide, there is Michigan's older population is a diverse population. It is a population that's growing. You can see that from 2010 to 2021, the growth of the 60 and over population in the state was was up to 2.5 million individuals, and so that is 65 and older is the largest growing segment of our aging population here in the state. And you can see on the remainder of the slide some of the characteristics of the older adult population when you look at education, poverty status, race, ethnicity, gender, and education. Next slide. When we talk about Michigan's aging network, as Senior Deputy Epke mentioned, with the recent reorganization to create the Behavioral, Physical Health, and Aging Services Administration, it really brought together the non-Medicaid side of aging programs that were formerly in the Aging Adult Services Agency with what was the Medical Service Administration Long-Term Care Supports and Services Bureau, and really brings together the Medicaid and non-Medicaid side of aging programs programs for older adults and for those needing long-term care. And if you look on the next slide, you can see on the non-Medicaid side, the aging network in Michigan is really a federal, state, local partnership, with the top of the slide being the U.S. Department of Health and Human Services, with the Administration on Aging within the Administration for Community Living, the Older Americans Act from 1965, which essentially sets the framework for the national and state aging network. In the middle of the chart, you see the State of Michigan Department of Health and Human Services, our Bureau of Aging, Community Living and Supports within the Behavioral, Physical Health and Aging Service Administration, and the Older Michiganians Act of 1981, which really defines the aging network in Michigan under the auspices of the Older Americans Act. You can also see in this chart the role of the State Long-Term Care Ombudsman, as well as the Michigan Commission on Services of the Aging, and their work with MDHHS to support older adults and caregivers across the state. And then towards the bottom of the chart, you can see there's more than 1,300 service providers across the state providing a variety of services. We have some of the representatives here today of some of those services, but those really form the important boots on the ground that provide nutrition programs, community-based programs, in-home services, and other services across the state. Next slide. For the state plan on aging, which 2024 is the first year of our current 3-year state plan on aging, it really is the framework and plan for aging services for the next 3 years across the state. This is a requirement of all state units on aging. The state unit on aging function is housed within BP-HASA at MDHHS. And the plan lays out 4 specific goals that we are working on over the next 3 years. And those would be to make sure there is good access to services, make sure there's a knowledge and awareness of what programs are out there, what services are out there, strengthen our partnerships across the state. As I mentioned in the previous slide, it really is a collaboration at the federal, state, and local level. And the state plan tries to support that notion of collaboration at the various levels to provide services. And then also to support optimal health and preserving independence of Michigan's aging population so that we can try to preserve independence of older adults across the state. And those are broad goals. They are also goals that tie to the service plans of our 16 regional area agencies on aging. So those plans would reflect the themes in the state's 3-year plan for providing services at the regional and local level. Next slide. For our non-Medicaid aging programs, you can see services are organized into a couple different areas. We have our care management in-home services, which help frail older adults stay in their home as long as possible. Those provide services like personal care, homemaker, and chore services in the home. You can see the service numbers for fiscal year 23 for our in-home and care management programs. The nutrition programs, the congregate meals program, the home delivered meals program, some of the longest operating programs in the aging network. They're the most visible programs. They also serve quite a number of older adults across the state, with more than 98,000 individuals served by both of those programs and serving 10.8 million meals. We also have programs that support caregivers. That could be adult daycare services. It could be respite care services. Could be caregiver support groups, caregiver training to support those informal caregivers. We know that most care is provided to older adults by informal caregivers, and these programs are intended to try to help those caregivers at the community level with their caregiving activities. And then community-based services are often the services that you find in senior centers across the state. They may be transportation programs. They may be health screening programs. They may be exercise programs. Those are the community-based programs at the local level, often found in senior centers and other community centers. And as far as funding goes for the non-Medicaid side of aging programs, you can see that more than half of the funds we receive are federal funds under the Older Americans Act. We do also receive significant state general funds, as well as some restricted and special funds under the Meridor Trust Fund, the state restricted funds, which are for respite care services, and some private revenues for our Senior Project Fresh program. I will say that with over half of the funds coming for these non-Medicaid aging services coming from federal sources, we do have to wrestle with the challenges of the federal budget. That is something that the Aging Network has to deal with. We've been operating under a number of continuing resolutions, and those continuing resolutions are very challenging when it comes to our local service providers attempting to try to plan for services for the remainder of the year. So that is certainly a challenge we face on the federal side when it comes to the non-Medicaid aging programs. As Director Epke mentioned, we reorganized in 21 and 2022 and try to really build a continuum of services across services for older adults, caregivers, and others needing long-term care, and bringing together, as I said, the former Aging Adult Services Agency with the Medicaid Service Administration Long-Term Care Supports and Services Bureau to really build that continuum, to really raise up those non-Medicaid aging programs to be a part of that continuum of services that we offer through MDHHS. And this slide will provide for you some of those other long-term care programs that we support through MDHHS. The My Health Link program, which is provided through our integrated care organizations, providing behavioral health, long-term care services, medical services to dual eligible individuals. We also have our My Choice Waiver program, providing home and community-based services for folks that have nursing home level of care and provide those services in the community. Our PACE programs around the state, which provide all-inclusive care to individuals 55 and older across the state, and our home health program, which provides personal care services to adults around the state. You can see the service numbers. And then, of course, on the facility side, you can see in the chart our nursing home funding provides nursing home care for about 33,500 individuals in nursing facilities across the state. And the funding chart for our Medicaid long-term care services you can see on the next chart. And you can see that there's significant dollars invested in both nursing home programs and then the variety of home and community-based programs that are identified on the chart. Some of our current initiatives and recent investments. Our My Health Link program is under CMS requirements from May of 2022, going to be transitioning to a highly integrated dual special need plan program. And that is a model, it's a specific type of Medicare Advantage plan designed to meet the needs of those dual eligibles for Medicare and Medicaid. It provides a number of opportunities for us in terms of moving from a demonstration project to a more permanent statewide project. It also allows us to build off some of the successes in the My Health Link program. And we do have a timeline for our transition. We will be issuing a request for proposal here early in 2024. We plan to award contracts in the fall of 2025, and our program will start January 1st, 2026. So it's a tight timeline, and we're looking forward to this transition as we've had a number of good opportunities and experiences with our My Health Link program. In terms of our nursing facility rate reform, we are working with the industry to take a look at nursing facility rate reform. We have a number of areas of the department that are looking at trying to move our rate process to more of an acuity-informed process to support health and safety of the workforce, to focus on quality, and to simplify the rate-setting process. These conversations have been going on and will continue to go on, and we're looking forward to partnering with the industry on looking at a way to reform our nursing home rate process. One of the biggest challenges facing both our facility side and our home and community-based side of long-term care supports and services, and certainly this impacts both Medicaid and non-Medicaid side of aging programs, is the shortage of direct care workers. We're looking at currently a shortage of 36,000 direct care workers across the state. You can see from the chart some descriptions of some of the types of work and some of the type of workers that fall under the direct care workforce. You can also see that these services are paid through Medicaid, through the Older Americans Act, through state aging funds, Medicare, and also by individuals directly hiring direct care workers. This problem, as I said, is one that is impacting all of our service delivery networks and certainly is a significant challenge for us. We have a couple of strategies. We have a variety of activities going on within the department and within our external partners and within state government. You can see some of those here. We have an internal workforce capacity steering committee, which tries to coordinate various activities going on across MDHHS and with our external partners. We have a direct care worker advocacy committee that is working, or advisory committee that's working on a number of strategies related to direct care workforce supports. We work with LEO on some specific grants that LEO has. We're also working with external organizations like the MPART Alliance, which is made up of advocates, others that hire direct care workers themselves, and of course MDHHS. So you can see the variety of activities that we're working on to try to address the direct care workforce issue. Next slide, we have some investments in the direct care workforce and more generally in programs and services for older adults. You can see over the last number of years, we've appreciated the support of the legislature and the governor's office on the direct care wage increases. We've implemented those. That certainly is an important part of a strategy in terms of supporting direct care workers. We've also had some direct care and non-clinical wage increases that also help some of the other folks outside of the, strictly speaking, the direct care workforce. And then there's been a number of activities identified in this chart that support senior centers, that support the Home Delivered Meals Program, the Senior Project Fresh program, our home and community-based services. We have some programs, we've had some grant funds supporting nursing and home infection control grants and nursing home recruitment, and retention, and training efforts. So there's a broad variety of additional investments and activities over the last couple of years that aim at both the direct care workforce, but more generally supporting the services and programs that serve older adults and caregivers. We have a home and community-based ARPA plan that was recently approved by the legislature as well as by CMS, and this focuses $189.7 million on investments to a couple key areas. One is to expand and make consistent access to long-term care services in the community, and you can see some of the projects we're funding within that expanded access bucket, if you will, of our ARPA plan, including our My Choice Presumptive Eligibility Program, a respite care and support caregiver support program, and a long-term care awareness and options counseling effort that we have underway. We also want to allow for a full continuum of care by supporting the direct care workforce. And you can see there's significant dollars that are part of that plan to support training, credentialing, recruitment, and support of direct care workers across the state. And then finally, there is an infrastructure support project that provides funding for our PACE programs across the state to build and expand and to add to their infrastructure to support more home and community-based services in the PACE program. For fiscal 25, we have a number of investments we wanted to highlight this morning. So the Department of Treasury has been working on a Caring for Michigan tax credit, and you can see that that tax credit is to support caregivers. These can be caregivers that are older adults, can be caregivers of younger people or children. The tax credit is up to $5,000 for eligible expenses. Those things may be adult day services, transportation, home modifications, equipment, home health aides, etc. It's a $37.5 million general fund revenue reduction to offset the amount of state income taxes that would be owed by caregivers. And we really think this is going to be helpful to support those caregivers because it can be an expense to provide care to, for example, an older adult. You may be a long distance caregiver. You may have to travel to provide care, as was mentioned, modifications to the home, et cetera. And so those expenses can be helped supported by the My Family Tax Credit. We also have funding proposed, $5 million proposed in the 2025 budget for the My Choice Structured Family Caregiving, and this would provide support to caregivers in the home for participants in the My Choice Waiver Program, and it would provide a stipend for those caregivers to support the individual in the home, and we think that that will support family caregivers who are trying to support a family member in the home and also improve the quality of care. And finally, and there is also a non-direct care wage investment in the 2025 budget of $14 million, and this is to provide increased wages to non-direct care nursing home staff, and those could be individuals that are involved in housekeeping, maintenance, plant operations, laundry, dining room assistants, et cetera. And again, that's to try to support that infrastructure that helps keep individuals supported in a nursing facility outside of the direct care workers themselves. And with that, I'd certainly happy to take any questions.
Well, thank you so much for your presentation. I just think that this is so useful for us legislators to have you put this all together because your department is so large and it can be hard for us to find the information we're looking for. So this is really precise and I really appreciate the work you did. I'm going to open it up to the members first. Rep. Bolin.
Thank you very much, Chair Morse, and thank you very much for being here and for the presentation. I have a question related to the PACE program, which I think is great, keeping more people, allowing them to age in place. And it looks as though it's going to be expanded, but you mentioned the shortage of roughly 36,000 people and expanding to some areas where they even have less people in the workforce. I mean, how are we going to expand a program and yet we don't have a workforce?
That's a great question, and it is a challenge. We do want to try to expand PACE. It's a great program. So, as you mentioned, there is funding in the HCBS ARPA plan to expand PACE, both existing PACEs and build infrastructure, and also try to expand PACE to Northeast Michigan, where there currently is no PACE program available. That said, the direct care workforce challenge continues to be one that we need to try to address. We have been working closely with the PACE Association and with individual PACEs to try to build support for direct care workers. I think that there's going to be a lot of inertia behind our HCBS ARPA plan when it comes to the training and credentialing and trying to attract workers into the direct care workforce. But it will be a challenge, and it is a challenge while we're trying to expand. We will have to focus on expanding the direct care workforce because if you don't have those direct care workers, it's very challenging to provide services across the state, as you've noted.
Thank you.
Rep. Price.
Thank you, Chair Morse. Thank you for your presentation today. My questions are also related to the recruitment and retention of the direct care workforce. Wondering if you have a sense of the need, how many unfilled positions we have. And I'm also curious about when there's high turnover, what is the approximate cost for refilling a position when it goes empty?
Great question. Thank you. The shortage we see now is approximately 36,000 direct care workers across both the home and community-based and institutional side of long-term care settings. In terms of the training and credentialing, that's one key. Certainly addressing wages and wage increases is important, but also training and credentialing that workforce to bring the level of skill up, both for the direct care worker to have higher level skills, but also to impact service quality across the state. I think also what we need to try to do is raise the profile of direct care work. It's important work. It's challenging work. That's one of the reasons why there's a challenge in terms of attracting direct care workers. When you're in a competitive economy, it's a difficult job. It's a fantastic job that they do, but it's a difficult one. So attracting people into that workforce and maintaining people that are in the workforce, keeping them there is important. Attracting folks often involves also building a career ladder. If you can get your foot in the door in direct care work, where can you go over the years in your career? And so that's an important part of it as well. So we really have a challenge to not just address wages, but also to support that workforce more broadly in terms of credentialing, training. And there is a high cost to turnover. And one of the opportunities, we've done a number of studies, we've worked with some external organizations to do studies, is to try to really paint the picture that it is less costly to train and bring somebody on to maintain them than it is to have a revolving door of people leaving and then needing to retrain them. And I think that's part of our goal, is to try to really paint that picture that if you bring somebody on, you train them, you support them, and keep them, in the long run, that employee is going to stick with you, and it's going to be less expensive than the constant turnover, because turnover can be 30 to 50% in direct care worker positions.
And I see the proposed increase for non-direct care wage, which I believe is the same that we were able to do last year for what we were able to invest per hour in direct care workers. Is there any proposal from the exec rec of increasing direct care work wage for this year?
In the 2025, there is not. We do build upon the wage increases of previous years, but there's not in the current 2024 a direct care worker pay increase that's proposed.
And when you may I have one more question, Chair? Thank you. When you talk to those representing direct care workers and asking for what they need to increase recruitment and retention, the supports that you're proposing in terms of counseling and letting them know what their career options are, is that what's being asked for, or is that more a wage or a combination? Curious what the direct care workers are asking for when we're asking, what do you need to be able to stay in this career? Thank you.
I certainly think the things that we have in terms of strategies for credentialing and training and a career path are things we are hearing from the direct care workforce. We do have, through the HCBS ARPA funding, an opportunity to invest in those activities. And so I think those align with what direct care workers have said they need. And we do have funding under the HCBS ARPA plan to try to support those efforts.
Thank you.
Rep. Green.
Thank you, Madam Chair. I have a couple of questions on a couple of topics. How would you like me to go, or?
I'll put you on.
Okay, wonderful. Thank you for being here. Looking at the direct care and as well as the indirect care, as we are out and about in our communities, we obviously talk with our partners and so on and so forth, and this is a world we all live in. Many of our partners are expressing concern as to how difficult it is to maintain the proper paperwork, and depending upon where the patient comes in, how much they get paid for certain time frames and so on and so forth. So the difficulty of meshing our partners that see multiple different types of patients. And then, so I guess that would also flow into that second component, not only our direct care. If we went with our indirect care, how in the world are they going to maintain that under this patient I get paid an extra this amount, under this type of patient I get paid this amount, when they're doing housekeeping or they're doing different? So my question, I guess, would be, is in both components, how can we make the system work so that our partners can utilize it effectively?
It's a great question, and we have heard concerns about trying to address where you have different workers within the workforce that may have some qualify for premium pay, others don't. I think we are always trying to look at streamline the administrative side of things. We obviously need to make sure that direct care wages and direct care pay gets to the direct care workers, so there's some level of tracking of those dollars. But we are certainly interested in ways to alleviate the administrative side of things so that our home care agencies and others that employ direct care workers can focus those workers on the work at hand. Some of the work that's been done is to, as I said, try to streamline the reporting. Some of the work has been done to try to make sure that we're expanding who's covered under the direct care pay in terms of what activities, what types of workers. I think you can see that in both the direct care, but also the investment in the non-direct care. So that is something that we are focused on, and we do hear from our local partners that less of that administrative burden is better for them.
Okay. I guess moving a little bit different topic. In the Medicaid reimbursement system, I know we've been looking specifically at AAAs. Are we looking at a new Medicaid reimbursement system for nursing, for skilled nursing facilities, for nursing facilities? And how is that implementation going?
Yeah, that's a great question, and we have been in conversations with the industry, a lot of really good conversations in terms of setting the overall objectives, which Scott briefly touched on. At this point, I think there's a couple of different models that are on the table, and I think there's agreement. I certainly don't want to speak for the industry in terms of there are different models. I think we just got to figure out which model to get to, and certainly with any new rate structure, there will be individuals that get more, and there will be individuals that get less. And so just kind of working through that transition too, to making sure that we understand that transition amount and what that looks like as we go forward. So I think, we'll continue to have those conversations. We're encouraged by the partnership that we have had, and really want to make sure that we have all the input from the industry to make sure that we can set that model up appropriately moving forward.
When are we expecting to be implemented? And then for us, are we expecting to have a huge increase in IT expenses?
So at this point, we don't have a specific implementation date, and partially we kind of went full force last year working with the industry, and there was a little bit of feedback about maybe slowing that a little bit because there is an implementation lead time. So we want to make sure whatever model we come up with, there's enough time for the industry to be able to implement, so we're still working through that details. And yes, I do think there will be an IT component associated with it as well.
Significant or?
Probably depends on your definition of significant. So certainly we will have to do some adjustments. Probably the biggest piece would be the time commitment of the upgrades to any investment or any technology. There certainly would be a monetary piece as well, but I think the time piece will be the major issue that we'll have to address.
Okay, thank you.
Rep Hood.
Thank you, Chairwoman Morse. I have questions about our dependent living situations and ombudsman. Our area agency on aging has flagged the need for additional ombudsman services in our region, and I'm curious if there is any effort to address that and to meet minimum standards for ombudsman oversight and care, and if we're seeing any stepwise progress toward that.
Yeah, thank you. So the Ombudsman Program certainly provides that important voice for residents in long-term care settings. There is a challenge with a growing aging population in terms of having an adequate number of ombudsmen across the state. Our ombudsman programs locally and at the state level do a fantastic job with the resources they received. We have been looking at some ways to try to address the program in terms of its ability to cover all the responsibilities that it has. We've recently been working through an update to the operating standards or the rules of the road, if you will, in terms of what's expected of the ombudsman to make sure that those expectations are in line with the resources. I do know there's also conversations related to potential funding for the ombudsman program, but we are in close contact with the ombudsman program, and we are certainly looking working with our State Commission on Aging of ways to better support the Ombudsman program across the state, because we do know that it's a challenge with the number of facilities, individuals the Ombudsman program has to try to support.
Do you have an estimate of the number of additional ombudsmen that we would need in the state to meet standards set in the industry of population to ombudsman?
Yeah, I think that's something we can send back to you if that's okay. We do have information about the number of facilities, the number of ombudsmen, and what is that mix of ombudsman versus numbers of facilities that they support. So we can send that information to you. We certainly do have that information. Yes.
Thanks, I appreciate that.
Rep, we do have a presentation coming up from the Ombudsman also, so they will speak to that. Yes, thank you for the question. Rep Steele.
Just real quick on the aging network programs, the non-Medicaid. I'm just curious on how aging Michigan residents qualify for those programs. How do they get into this network?
That's a great question. So there is some different eligibility criteria when it comes to Medicaid-funded long-term care services versus the non-Medicaid side. Generally speaking, for the aging network programs that you see on Chart 7, those programs are open to individuals age 16 older. There is not an income component. Older Americans Act programs and Older Michiganians Act programs do not do means testing. We do target for those that are either economically or socially isolated. We do target, but there is no income qualifications. There are some qualifications in terms of functional status when it comes to the need for in-home services or home-delivered meals versus services in the community. But essentially for individuals that are 16 over, if they qualify functionally for the service, they are qualified for Older Americans Act and Older Michiganians Act programs. They are grant-funded programs, so there is limited funding for those programs, but that eligibility is really based on age, again, with some targeting criteria. 60, sorry.
They're through local programs, and
Yeah.
then they're like within a community, like Meals on Wheels as an example.
Yes.
And then whatever the community does, they get the grant, and then they facilitate it to the people that live in those communities.
Yeah.
I'm just trying to figure out how
Yes.
it works. Okay.
So the aging network service providers are a broad variety. As I said, there's 1,300 providers across the state. Those can be home care agencies, councils and commissions on aging at the county level, other providers at the local level. They can also access the services through the local area agency on aging, which can refer them out to a local service provider. So there are a lot of contact points at the local level for aging network programs.
Okay, Rep O'Neill.
Thank you, Madam Chair. Thank you, Mr. Director, for being here, your team. Two-part question. What is the status of our current Caregiver Resource Centers concept that we awarded appropriation of $5 million this current budget? Follow-up question is, are we continuing that funding in this model proposal this year?
So great question, and do appreciate the support for the Caregiver Resource. We did issue grants out to the area agencies on aging to start up those programs for fiscal year 24. So those grants are out and in place, and we are working closely with the area agencies on aging and the Area Agency Association on the Caregiver Resource Center. There is additional dollars that we've identified in our HCBS ARPA plan that are also being put towards that Caregiver Resource Center concept. So it is up and moving, and we do expect good things out of it, and we are working closely with the area agencies and their association to make sure that the Caregiver Resource Center is something that is very successful for us in terms of supporting caregivers across the state.
Thank you, Madam Chair.
Okay, thank you. So one last question. We never have enough time for all these things, but with regard to the state plan on aging, I am curious, how do you come up with the mixture of programs that you offer in terms of sort of comparing nursing homes, PACE, My Choice? How do you come up with the percentages of the mix of those? Because there is some information that Michigan is 36th on the mix of nursing homes versus in-home care. So can you just talk about how you arrived at what we're doing and what you see as the future of that mix?
So specific to the state plan on aging, the state plan on aging is specifically focused on Older Americans Act programs. And so we are focused in the state plan on how are we going to provide nutrition services and in-home services under the Older Americans Act and Older Michiganians Act. There is conversation in the state plan more broadly about supporting older adults outside of, strictly speaking, those fund sources. But the state plan on aging is a particular requirement of the Older Americans Act, so it kind of focuses on those services. But more broadly, we understand there is a continuum of services, and as Director Epke mentioned, one of the things that we want to try to further in the reorganization was to really build up the non-Medicaid side of aging programs alongside our Medicaid-funded long-term care programs. We do see a continuum that runs from community-based programs to facility-based programs. Those are all part of that continuum. Some of that is the appropriations process in terms of what funds are available, but certainly we see key to really support both our non-Medicaid aging programs alongside with our Medicaid-funded aging programs.
But in terms of like, we have this many spaces for nursing homes. I'm going to just take it down to like an elementary level. This number of spaces for nursing homes, this number of spaces for My Choice, this number of spaces for PACE. And, you know, there are certain groups that advocate for more home-based programs versus nursing homes. But my concern there is are we thinking ahead to how many nursing home spaces will we need with the additional, you know, population that is aging? Are we thinking about how many spaces we sort of need to keep there as compared to home-based programs when there's a lot of advocacy around expanding home-based programs? I think it's all important. I'm just trying to figure out how do we arrive at what the needs are?
So the bureau that I work in most specifically focuses on the home and community-based programs. And so we certainly take a look at aging trends, what the population trends are, what we have in terms of funding, and to try to plan for, and the state plan on aging is one vehicle to do that, try to plan for where do we need to be in terms of home and community-based programs a year from now, 5 years from now, 10 years from now. And so we do try to plan for that. I can't speak as much to the planning on the nursing home side, but as far as home and community-based programs, we are looking all the time at what capacity is and then what challenges do we face, whether that's funding challenges in the federal budget, whether that's direct care workforce shortages. Those all play into that. How do we plan for the need with a growing aging population? So that's sort of the way we look at it on the home and community-based side of things.
Okay, well, that's all the time we have for today, but thank you so much. Members, if you have any additional questions, we're happy to forward them to the department. Thank you for your testimony. Thank you for your work. Next, we're going to invite Richie Farron, Vice President of Government Services for the Healthcare Association Michigan. And if you could, Richie, 5 minutes for the presentation as best as you can, and then we'll allow as many questions as we have time for. Thank you.
Absolutely. I'll be brief. Much of what I was going to touch on, the department did a good job highlighting as well. So Richie Farron, VP of Government Services with the Healthcare Association of Michigan. Thank you, Chair, for the opportunity to testify. We represent about 360 nursing facilities across the state and about 240 assisted living communities. Your skilled nursing settings are usually a higher acuity, older population. 65% of those residents are Medicaid beneficiaries, which is obviously where we interact most with all of you. Then there's a Medicare for a proportion for your short stay rehabs. The assisted living communities include AFCs, HFAs, non-licensed, unlicensed independent living, and usually a lower acuity, younger population than in the SNF setting. So as Michigan lawmakers have been and will continue to be a critical for long-term care providers in Michigan in the years to come. As we all know, the number of people over the age of 65 is increasing. Again, the department did an excellent job highlighting the aging of our population. As I share with you the state of the sector, you will not be surprised to hear that workforce is our #1 issue for our members. As you can see from the slides before you, nursing facilities were hit hardest by the pandemic and the ensuing economic challenges. There are still more than 130,000 job openings nationwide. We estimate over 5,000 here in just the state of Michigan, and 99% of nursing facilities currently have job openings. Nursing facilities are doing everything they can to attract and retain a strong workforce. Wages have increased by more than 20% over the last several years. They are offering retention bonuses, recruitment bonuses, tuition reimbursement, assistance with childcare and transportation, and much more. Even with these efforts, the workforce challenges do persist, and is mainly due to a lack of interested or qualified candidates. And unfortunately, the workforce challenges are leading to access issues. You can see the numbers that we provided. Nearly half nursing homes are limiting new admissions, so it is becoming an issue of access for care for those seniors who do need that 24/7 nursing care. Again, these workforce challenges come at a time when the population continues to age and the demand for these services is going to increase, especially as the baby boomers begin turning 80 in 2026. So in light of all of this, as providers seek to address these workforce challenges, the stability of the profession continues to be threatened by three major issues that are creating significant uncertainty for the future. Items 1 and 2 on this slides you will recognize from the information that the MDHHS just presented. But I'll start first at the federal level, where CMS issued a proposed rule last year that would increase already existing staffing ratios to unattainable levels. The mandate would require nursing facilities to hire an additional 100,000 caregivers at a cost of nearly $7 billion annually nationwide. In Michigan alone, we estimate that 92% of Michigan facilities would not be able to meet the criteria of that staffing mandate. And nearly 5,000 beds would have to be taken out of service in Michigan, more than 10% of the available beds, to meet those ratios. Michigan providers already have, as I stated, thousands of job openings that they are unable to fill, and the rule would require hiring an additional 2,600 CNAs and nearly 500 nurses to the tune of $145 million annually, which will have a significant impact on the state Medicaid budget. I'll move on quickly to the rate reform efforts that MDHHS just referenced. I want to thank MDHHS for taking a collaborative effort, taking provider and industry proposals and input on the issue, and we look forward to continuing our work with the department to come up with a system that works for residents, staff, the state alike. It is crucial. This is a significant change. The current system has been in place for 30 years. It's crucial to have a smooth transition and enough time for both the state and providers to transition. We referenced, I think, last year in the 2024 executive recommendation in the budget, there was a proposal for $110 million for transition funding. That ultimately wasn't included and wasn't included this year, as we have not come up with a new system. But once we do, it is critical that some funding is included to ensure Medicaid rates are not reduced for many providers. The third major issue is the transition of MyHealthLink to the HIDE SNP. This essentially brings managed Medicaid to Michigan, to long-term care. It's significant change from the current fee-for-service structure. And again, we're working with MDHHS and have begun meetings actually with health plans as well to ensure that we can have a smooth transition here. So in conclusion, what can you all do to help? And I'd like to share there are a couple of things. First, the direct care and non-clinical wage increases have proven to be very beneficial. We're happy to see those proposed in the exec rec this year and to continue. Our request would be that these are sustainable going forward in years to come, as this is the wage rate that the employees are used to now, and we don't want to pull that rug out from under them. Second, just to reiterate, when we do move to a new system, new Medicaid reimbursement system, it is critical to have hold harmless and additional funding there to ensure Medicaid rates don't take a hit. Lastly, we are exploring potential boilerplate to update some Medicaid policies to reflect the workforce challenges and the accompanying operational changes that are underway, given the current workforce challenges that providers are facing. So I'll close there with just thanking the committee and the legislature, MDHHS, and the administration for all the resources directed to the profession over these several challenging years we've experienced, and answer any questions the committee may have.
Appreciate your testimony today. Any questions from the members? Rep. Meerman?
Thanks, Chair Morris. Could you give a little overview of how we're doing on filling positions in nursing homes compared to last year? I'm assuming it's improving some, or are we still in dire straits?
It is improving. If you would have talked to me a year ago or more, the number would have been closer to 9,000. I think at the peak, when things were at their worst during the pandemic, it would have been over 10,000 job openings, and now we're closer to 5,000. So you could see just nationwide on the slides how it has begun recovering since about 2 years ago now. So things are improving, but it's a numbers game. We just, again, going back to the federal staffing mandate, we all want to hire more workers, and providers are doing everything they can to attract those workers. It's just you need a pool of workers there to pull from, and unfortunately that's not the case right now.
You mentioned the CMS rule change. So where is that in the process? How much, do we think it's happening? We don't really know. When would it happen if it did? Because that obviously is a huge potential impact on our Medicaid, and we need to start prepping for that if that is an eventuality.
It's imminent. So it was just sent to the OMB, and it's our national association is monitoring this closely, and they're reporting that this could drop really any day now. The good news is there's still a little bit of time. The ratios that would come into place would not take effect for urban areas for 2 years and for rural areas for 3 years. So we'd have time to prepare for it and to build up to it. But even with that extended timeline, does the workforce rebound in the next several years to allow facilities to meet those ratios? Likely not, which means you are just limiting access to make sure you meet those ratios.
But interestingly, this is a nationwide problem. We look at, you're talking, that's nationwide. So
It is, yeah.
it's not just us in Michigan. It'll be interesting, I guess, to see where we end up there.
There are efforts within Congress to try to mitigate some of that, so
Okay.
it may take a different change, but we're expecting it to drop imminently. And then I can answer your previous question about the bed need for nursing facilities.
Oh, yes, please.
Yeah. So it's actually, the licensed beds, and we are a certificate of need state, so the licensed bed and the number of beds needed, it's a formula, bed need methodology conducted through the Certificate of Need Commission. They contract actually with a third party and it's in the review standards, so you can look at how that's identified. And actually, they paused updating the bed need because of the data was a little skewed due to the pandemic, but that should be updated next year. And I think right now we're at about 46,000 licensed beds in the state.
Thank you for that. Okay. Thank you for your testimony. Appreciate you
you.
being here today.
Appreciate it.
Next, we have Bob Brown, Executive Director, Region 7, and Dan Salita, Director, Region 3A of the Area Agencies on Aging Association, Michigan. Welcome. And we'll ask that you keep your presentation part to 5 minutes so we have some time for a few questions. Thank you.
Good morning, members of the committee. We appreciate your time this morning. As mentioned, my name is Don Saldia with Region 3A, Kalamazoo County. With me is Bob Brown, Region 7, based in Bay City, Michigan. Go ahead and get started here. So I'm sure you're very familiar with the AAAs and the mission. Arguably, we are here to keep older adults aging at home by providing them supports and braiding all of the various funding sources that come down to each of the local counties and each individual area agency on aging. Of course, Older Americans Act, state, federal dollars, and even local funding. We mesh those together to provide those services that are essential for our older adults to age with dignity, with independence, in home, in their community, being part of their communities. And wanted to jump directly into the positive effects that this committee, that this funding allocated does for each and every one of the area agencies on aging, specifically the Long-Term Care Ombudsman Program. Representative Hood, you had a question earlier about how many long-term care ombudsmen do we need to meet that mission of getting down to that standard. 33 is that number. And with those 33 additional staff members, that gets us down to the national average of 1 to 2,000 ratio for long-term care ombudsmen to licensed facility beds. If you want to scale that up to the national average by getting to that point, then we would rank 29th in the nation. So even just getting to that standard, there is absolutely much more we can do to serve residents and long-term care facilities. So here in the state, we know that there's over 4,600 licensed facilities and currently only 20 long-term care ombudsmen. And of note, some of those ombudsmen are actually funded by local funding. Specifically in Kalamazoo, one of our two is funded by a local senior millage. So of course, to get to this 1 to 2,000 ratio, that would help and ensure that our older adults are protected, that their rights are given to them, and if they want, to either age at a facility or even to get that advocacy to see if they can age back in their community, we need to increase that funding and to take into consideration an increase to get to our 33 long-term care ombudsmen. That would be about a $3 million allocation in addition to what is already budgeted.
If I may, Dan, just to clarify something Dan said, we appreciate your funding. We are asking for more. This is a very important program to all of us, all 16 of us, so much that many of us subsidize the program with our own excess funding or other matching money. So, it needs to improve because these folks are the only voice many of these people have because their families are gone. So we'd appreciate you looking at that.
Absolutely, absolutely. And to move into our second point, we know that the direct care worker crisis is an ongoing issue. And because of that, we know that there's going to be that increased reliance on family and informal caregivers. So thank you for that initial allocation to support those caregiver resource centers. Here in Kalamazoo, we are actually part of the health department, our area agency on aging. We are actually creating a local caregiver resource center embedded within the public health department to make sure that not only is this a state initiative, but we are drilling this down into a public health initiative as well to support caregivers of older adults. And so with that initial allocation, it's going to give us that framework, that foundation to build these centers, either in person or digitally, and an ongoing allocation will make sure that our caregivers in our area, even with a direct care worker shortage, are supported by area agencies on aging, that they know that the community that they live in, that they support the older adult, they have that support and those resources needed for them to age at home as well.
And Dan, another crucial area, and what isn't mentioned in this report is that we're reaching out. There's a network. It's not just us alone. It's your local counties on aging, departments on aging. In fact, and you're already moving. We're already moving with the Council on Aging's, our Department on Aging's, to try and get this out there because I only have one site, and I have 10 counties. So I got to be out in 10 counties, and the only way to make this work is through a network. And you're already doing things.
Absolutely, absolutely. So we thank you for the support, and of course, we look forward to the additional support and the ongoing decisions from this committee so we could support our caregivers in each and every one of our townships. I'll hand it over to you.
My Choice program in the future, I did hear that. So I hope it gets melt with whatever the state is moving to. In Ohio, one of the things they did is they did melt it in statute, long-term support services, and we hope that this committee can look at that at some point. We're very crucial. There's some issues we have, so one of them is the asset. You'll see that in our report. Hasn't been done, I think, since the 90s. Yep, hasn't been increased since the 90s, so we know that inflation has affected that. But even so, at that point, it was low. So there are a few protection exclusions, the family home. We hope that you look at those things and protect our local people, especially in the rural where a lot of times that property is also income for the family. The other thing is there is no spend down feature in long-term support services such as My Choice Waiver Program. One of the ways to address that would be looking at something called Miller Trust. So I hope you'll take the time Yes, Representative O'Neill, I know you're listening to me about that. That would allow us to do spend down like some other long-term support services and hold those people. And I'm going to go outside the box and outside the script. My mother was held hostage. I mean, she is at the point where she needs a nursing home now, but she was held hostage. She couldn't qualify for PACE or My Choice Waiver Program because she was making $300 more because my dad was a teacher back in the 60s and got in retirement based on the 60s. And now she's 95 or 96. So I really hope that you look at the spend down and this asset limit. It really does need to change. Tweak, if you want to call it that. The other numbers speak for themselves, and I appreciate that. And Dan, is there anything else we need to cover?
No, and of course, Bob and I are just representatives of 2 of the 16 area agencies on aging, and the work that is being done in each of our townships, each in our communities, of course, is based on the hard work of the agencies and, of course, the advocacy and the considerations from this committee. So we appreciate your time, your considerations, and please let us know how else we can assist.
Thank you very much for your presentation. We appreciate some very intentional language there, so you can guide us to exactly what you're looking for. Any questions? No question. Oh, Rep. Bolin.
Thank you very much. Thank you for being here, and thank you for your work. As one who takes care of an elderly aunt, I really do appreciate having the services available, although we're short of people, right? So my question is, it follows up to, I think it was Rep. Hood's question about the Ombudsman program. And I'm just wondering, you're recommending this 1 to 2,000 ratio. What is the national average?
So that 1 to 2,000 is the national average.
That's
yep,
the
that
average.
is the national.
Okay,
yes.
so that's not the optimal.
Correct. Yep.
Okay.
And even with that, even if we get to that 1 to 2,000, that still, gets us ranked as 29th.
And so, do you have anything that indicates what the demand is? I mean, are we getting a lot of inquiries that are not being met? Is it that they're not getting out there with their regular visits according to the handbook?
So I would say, one of the big considerations too, especially from the AAAs, is, who are we missing? We're doing a very great job, but with that number of beds, we want to make sure that we are able to have that long-term care ombudsman available to all of those facilities.
I appreciate that. As one who started out as a rec therapist with a specialty in geriatrics, I spent a lot of time working in nursing homes, and so I do understand the role, and I just really, there's such a large request for services. We have aging population. Somebody mentioned 25% of the population is over 60, and so I just am asking as an appropriator, showing me what the demonstrated need is, not the perceived need. So do you have anything on that?
And Bob, feel free to jump in, but also another thing to take into consideration, even with the funding, is the funding formula was strictly based off of licensed nursing facilities, not taking into consideration the homes for the age or adult foster care homes, to other categories of long-term care that our local or long-term care ombudsman actually oversee and go into. So in terms of just the demand, the allocations and the numbers that we're working with current budgets, arguably only look at nursing facilities and not those other additional types of long-term care facilities.
So when you put the time constraint of travel, such as my region planning services area has 10 counties, and my one ombudsman, her name's April, if you anecdotally want to, this is an anecdote, but if you want to talk to her and make it personal, I'm sure she would share a lot of stories, or your local ombudsman. But right now she's visiting approximately 6 clients a day through this inverse thing. That includes travel time and everything like that. And back to Dan's point, who aren't we reaching with these restrictions? We should be reaching, in my planning service area that has 1 ombudsman for 10 counties, we're reaching 6 a day. We should be reaching 20 a day. And there is a need for it. She has a list, she reaches out, and I'm sure she's telling you about those other folks that aren't getting reached outside the time constraint she's been given, because she's that kind of person. And once you meet an ombudsman, you'll understand what I'm talking about. They are so dedicated. I've never seen a profession so dedicated to these folks than an ombudsman. And I believe Sally's in the audience too, that runs the state long-term ombudsman, or she was here earlier, but maybe you have a side section in regards to the ombudsman program and bring all the ombudsmen in here for a committee meeting. And I'm sorry, Madam Chair, I wasn't being
No, that's okay. They're coming up next, so you will hear from them. Thank you so much for the presentation from the Area Agencies on Aging. We really appreciate your work, and we will continue to partner with you to make sure our seniors have the best quality of life. Next up, Sally Pung, Michigan Long-Term Care Ombudsman, and Allison Herschel, Director Managing Attorney of the Michigan Elder Justice Coalition.
Good morning. Chair Morris and members of the committee. I'm Sally Pung. I'm the State Long-Term Care Ombudsman. The Michigan Long-Term Care Ombudsman Program, which I direct, seeks to improve the quality of care and quality of life for over 104,000 people living in over 4,500 nursing homes, adult foster care homes, and homes for the aged across Michigan. I'm pleased to be here today to speak about program service delivery and the needed resources to extend our program to ensure that residents have access to our program. I think that speaks to the unmet need. Our program started many, many decades ago as a nursing home advocacy program, and since then we've added those other settings, and we know that the majority of our work is done in nursing homes, so we can only imagine the unmet need in those adult foster care and home for age settings. Through the network of our local ombudsman and about 10, 11 volunteers, we work to investigate and resolve resident concerns, but only at the direction of the resident. Concerns related to abuse, neglect, exploitation, eviction or discharge, hospital dumping, functional eligibility for Medicaid, guardianship, or harm to a resident are our top priorities, which require a response within 2 working days. All other issues, which are as equally important to the resident, cold coffee, lost clothing, those things are still important to residents, require a response within 7 working days. So generally, though, ombudsmen respond to those high priority concerns within a day or the day that they receive them, and all other concerns within a few working days. But they have to prioritize complaint work over other ombudsman services. So I'll try to go quickly. I know we're short on time. So in FY23, I shared with you the amount of cases that we completed in that year, over 3,200 with just 20 people, closed 3,200 cases. The complaints that come in those cases are things from involuntary discharge and eviction, staff's failure to respond to residents who say, my call light's been on for hours, I've been in a wet brief overnight, no one's here to help me eat. You know, we're seeing a lot of weight loss. Rights and preferences of residents. Personal hygiene. Again, showers were a big issue in the last year for residents. Medications, either not getting their medications timely or not getting the correct meds. Dignity, respect, and staff attitudes. How they're treated. You know, being validated as a person. Living in a less restricted setting, so our ombudsmen do help identify residents who can transition with community services. And the last top of our list was personal property. So I always think of how these topics hit the basic needs that residents have for quality of life and quality of care. And although we saw a slight increase in our complaints in FY23, we recognize that a growing number of residents are not comfortable consenting to the ombudsman investigation or filing a complaint with our state survey agency due to a fear of retaliation. And as much as we can try to reassure them, they're the ones living there 24 hours a day, and they are the ones that have to, you know, either have their needs met or face some retaliation in some homes. We also hear from residents that complaining won't do any good. They really have come to terms with the staffing crisis and know that complaining won't change things for them. Last week, I received 2 communications from family members who've lost their loved ones in nursing homes. Following the resident's death, they wrote to share that they had such poor care, including abuse and falls. And each family member stated that they did not want to subject their loved one to the potential retaliation, but felt they needed to report these concerns to us after their death. Those are really telling statements that you feel you can't have a voice, and you can't even go to the program that can help advocate for you and have a voice for you because you're fearful of retaliation. So we do a number of other things which I included in our handout. I won't read through those now. And as you heard from our last presenters, there is a national recommendation to staff the program at 1 to 2,000 that came out of the National Academies of Science, Engineering, and Medicine report from 1995. And they looked at ombudsman service delivery and said that that's the recommended funding that a state should have available to ensure appropriate ombudsman services. Now, I think in 1995, there were probably less complex issues in nursing homes than what we see today. So I agree that 1 to 2,000 will definitely help, but I don't know that that's the benchmark that we want to end at. We already heard from other presenters about our current ratios and where those are at. And again, I included them in the handout, so I won't go over those today. So in closing, I just want to say how much I appreciate the opportunity to speak with you today regarding the long-term care ombudsman program service delivery and the needs for expanding program resources. I can't say enough about the wonderful work that those 20 individuals do, along with our volunteers, in being out there for residents, working extended hours, holidays, taking their phone on vacation. They are such a dedicated group, and it's because they care so much for these residents that are living in these homes, and they feel sometimes they are their only resource. So thank you for any consideration you can give to our program to help meet those unmet needs that are out there, not only for AFC and home for aged residents, but for those that are in nursing homes who don't feel they can speak up yet. With that, I just wanted to turn it over to Allison Herschel.
I know we're very short of time, so I'll take less than a minute, but I did want to provide some context for the federal proposed staffing rule that Mr. Farron referenced. I just wanted to explain that more than 20 years ago, there was a highly regarded, well-respected study that showed that residents, to get basic needs met, need 4.1 hours of care per resident per day. That study looked at how long does it actually take to take someone to the bathroom or to give them, to help feed them their meal. And more than 20 years ago, it was 4.1 hours per resident per day, a standard we've all accepted for and hope we could achieve. The rule, I have to say candidly, we were shocked when the rule came out, and it required only 3.0 hours per resident per day, far below that 4.1 standard we have all acknowledged for so long. The rule would include a long implementation period, and there are waivers available for facilities who can't meet it under the proposed rule. So I just wanted to emphasize two things. One is that the rule that was described as, potentially, or was suggested could be catastrophic for residents, is a standard that acknowledges we will not be meeting residents' basic needs because it was proposed at 3.0 hours instead of 4.1. The second thing I want to say is there's a wonderful website that CMS maintains called Care Compare, and if you look at that, you can look on information about every nursing home in the state. It tells you what the statewide staffing average is and what the national one is. The state standard now, according to CMS, is 3 hours and 53 minutes. So the state average is almost an hour above what the proposed reg requested or proposed as at the 3.0 level. And I just wanted to provide that context. Thank you very much.
Okay, thank you for your testimony. Seeing no questions, I really appreciate it. I know it was quick, but obviously everyone wanted to hear from the ombudsman. So appreciate your quick testimony and highlighting the information as well about the proposed ratio change. So thank you for being here.
Thank you.
I'm sorry. Oh.
Just a quick question.
Yep, go ahead.
Thank you so much, Chairwoman Morse. So I was looking at your presentation, and you place Michigan amongst Minnesota, Wisconsin, Ohio being the best standard here. We always hesitate to shout them out, but when they're the competition, we want to make sure we're getting ahead, right? So tell me, this has Ohio at 1 ombudsman to 2,004 patients, but you place that at the mid-range among states overall. So if we're looking at top 10 states in terms of this ratio, what does that begin to look like?
I think I'd have to pull that data for you. What I provided here was just kind of a list of homes or states that had similar number of beds that they served and
Okay.
pulled their state funding. And again, this is from fiscal year 19, so it may have been updated. This was the most recent data. And I just wanted to also point out, if I could, thank you, Representative Hood, that Minnesota, since fiscal year 19, has received, I believe, 2 significant increases in their state funding. So it really wasn't to rank the states by who had the best ratios, rather to look at states that had similar bed requirements for the ombudsman program and look at what does their state funding look like, and then what does that look like in the number of full-time employees that they have working in the ombudsman program.
Great.
I hope
and
that's
then
helpful.
You'll be able to follow up with those top 10 measures. So we're looking at the best performers and how we might compare. Thank you
Sure.
so much.
Thank you.
Yes.
Thank you, Rep. Hood. Thanks again for your testimony. And last but not least, Terry Langley from the Disability Network of Michigan. Thank you for your patience.
Thank you, Madam Chair. Definitely last but not least, my voice here is on behalf of the Direct Care Worker Wage Coalition that my membership, the Disability Network of Michigan, is a member. We are 14 members who provide services, mostly across ability services, and behavioral services are one of those items. Like the other members of this coalition, Disability Network Michigan seeks to empower and support people with disabilities to live independent lives, making their own decisions about how and where they live, work, and engage in their communities. This type of decision-making is called person-centered support, and every person deserves the support, including those with disabilities, as well as those who are aging. I'm here to request your continued support of programs and initiatives that help provide services many older adults and people with disabilities need to live in their communities. During the past 3 years, the legislature, including many of you, have been working to increase direct care worker compensation, and the coalition is grateful for your efforts. While the governor's proposed fiscal year 25 budget maintains the 85-cent increase from last year, the cost of living continues to rise, and the ability to survive on those wages lowers. Because direct care worker wages in Michigan's behavioral health system are directly tied to Medicaid funding, which has not kept pace with the needs of our state, these workers bring home very small paychecks and often have no medical or other benefits. Most direct care workers in Michigan make an average of $16 an hour. That's an average of $16 an hour for the work that they do. Many are leaving the profession. They're going down the street and they're working at fast food restaurants because the pay is more and the work is less. This exodus is causing thousands of Michigan residents to face emergency situations in which care is not available to them, chronic or extended hospitalizations, and I'm not talking just weeks, I'm talking months of hospitalizations, dependence on family members for ongoing care, and most important of all, a loss of their independence. To help address the lack of available direct care workers in Michigan, our coalition is asking the legislature to set a $20 per hour minimum wage for the state's 50,000 direct care workers within the behavioral health system. We can agree that long-term statewide strategies to support direct care workers who provide high-quality, person-centered support are needed. To best support this essential workforce and the individuals and families that rely on it so desperately, we know it will require all of us in this room have come together today to plead with you, to work with us, to make sure that this workforce is elevated to the point where they want to continue and we want to grow that workforce. We know it will require to roll up our sleeves and have difficult conversations. There's a crisis in our state, and I don't say that word lightly. When it comes to the number of direct care workers and the individuals and families who depend on them, we heard today that there are 36,000. We're looking at a shortage of 36,000 direct care workers. While one part of the challenge can be met by increasing wages, there are additional ways to combat this crisis. Some of those include build better pathways to direct care worker jobs and use data relative to the number of direct care workers available in an area. This could help communities when looking to attract new jobs and employers. Employers often provide this information to use as incentives, especially in competitive fields. This information can be crucial for employees who may have family situations that depend on direct care workers. Showing prospective employees that Michigan is a place where people with disabilities and older Americans can thrive is a sound economic development practice. Another option is to elevate the profession, and you heard earlier about elevating that profession. Creating an accessible career pathway to professionalize the field is also a sound economic development practice. The department recently invested $25 million through a grant awarded to Michigan State University to do just this. That's an exciting announcement that they just had, and that's a step in the right direction. Last month, the federal government announced its efforts to address the crisis caused by direct care worker shortage. The U.S. Department of Health and Human Services announced several new initiatives and resources from the Administration on Community Living's Direct Care Workforce Strategy Center. These include technical assistance opportunities to help states strengthen their systems for recruiting, retaining, and developing direct care workers, and an online hub to connect states, stakeholders, and communities to best practices and other resources related to this shortage. Many of us have already been in situations where loved ones, through illness or injury, have needed care. Some care is temporary. For the population where hospitalization or nursing home or assisted living facilities are not necessary or even their choice, direct care workers are the difference in the quality of life that they experience. Finally, I ask that this committee truly weigh the cost of implementing policies that will help address this crisis that is upon us against the cost of inaction. The state's return on investment cannot be disputed. We know it is far more expensive for the state to pay for more people to be unnecessarily hospitalized or to be thrown in assisted living facilities or nursing homes, far more expensive than the cost of care this profession provides. Thank you for your time and attention to this very important matter.
Thank you for your testimony this morning, almost afternoon. All right, we're going to allow one question from Rep. Price, and then we're going to have to close. Go ahead, Rep. Price.
Thank you for your advocacy here today. And this proposed $4 increase for direct care workers, can you talk about the impact that that could have?
I would love to talk about the impact that that could happen. It not only provides direct care workers additional money to support themselves and their families, but it also helps people that they're caring for to live a greater life, to be out in their community more, and to put their dollars out in the community. It is very much a rippling effect. And to quantify it, I'm not your person. I'm terrible at the math, but I can tell you that the communities that we work with, knowing that we keep people in their homes and we don't have them taking up other resources for more needed people to be in nursing homes, that is a ripple effect. Is what I said. They are shopping more. They are providing for their families. It truly is one of those ripple effects that is difficult for me even to quantify, given my lack of mathematical skills. But also, the list goes on. There are truly far more benefits of a small investment of a $4 increase than there are to do nothing. And like I said, I do want to make sure that everybody understands that the appreciation that we have for the 85-cent increase, it's just not enough.
Well, thank you, Terry, for being here today. Thank you to all of our presenters for your information. Members of the committee, if you have any follow-up questions, we're happy to provide the information on who presented today. Rep. Skaggs moves to excuse absent members. Hearing no objection, absent members are excused. And seeing no further business, this meeting is adjourned.